Hello, everyone. This is Jana Bitton. I'm the Executive Director for the Oregon Center for Nursing, and I just want to thank you all for joining us for lunch today. We are really excited to be able to offer this webinar for you about assessing and preparing your workforce for surge capacity. For the people that are on the call today that are not quite familiar with who we are the Oregon Center for Nursing. We are the state's nursing workforce center. And what that means is our job is to take a look at what the nursing workforce looks like in the state, so we can address any shortages and any kind of workforce maldistribution that we have. So our mission is right there. Our job is to support support research and collaboration for Oregon's nursing workforce, so we can have informed, well-prepared, diverse, and exceptional nursing professionals. During the COVID-19 response, we basically have responded to the crisis by making data available about the nursing workforce so that people can make good policy decisions. But then we've also been convening stakeholders on Fridays. We've been holding a weekly Friday huddle at 8 a.m. It's very similar to this, where it's a webinar that you can call in, and it's just a discussion time where people will have the opportunity to talk about things that are happening at their facilities and be able to collaborate, work with each other so that we can all work together to try to address the situation as best we can. This particular webinar that we're putting on today with Troy is a follow-up from some of the things that we have been hearing on the webinars, or excuse me, on the huddles for the last couple of weeks, about a need to be able to be prepared for the surge of patients, and also to be able to scale up our staff for that. So I'm going to turn the time over to Troy. After we're done, Troy's going to, after his presentation, Troy's going to be available to answer some questions. So we're going to switch it over to Troy right now. Dr. Troy Larkin is an Oregon native, and he's been a nurse for 28 years. He's worked in emergency trauma, PACU, and critical care settings. He's taught nursing in undergraduate and graduate programs and served as the emergency clinical development specialist for Providence in Oregon before moving to a director role overseeing Providence's clinical education services within the state. He now serves as the executive director for the Nursing Outcomes and Education for Providence Nursing Institute, which directs nursing education and practice across 52 hospitals in 7 states, along with numerous community and ambulatory services. Dr. Larkin holds a degree in nursing from Clackamas Community College, a baccalaureate degree in nursing from the University of Portland, a master's in community and population-based nursing from Washington State University, and a PhD in nursing from the University of Hawaii. Troy is a longtime supporter of the Oregon Center for Nursing, and he's been a board member for the last 4 years. So Troy, thank you very much for doing this, and I'm going to turn it all over to you.
Thank you very much, everyone, for taking some time at what I know is a very busy time for you. I was really struck in talking with some of my nursing colleagues in clinical education and staff development about what we're being asked to do in preparing our caregivers, our nurses, our technicians, other professionals for what we believe will be a significant surge of patients in the coming days and weeks ahead. Providence has had the first COVID patient in the United States at Providence Everett Medical Center in Everett, Washington. We have had significant impact in Swedish and Everett. We've been caring for a lot of COVID patients, and of course in Oregon and California. And it's really caused us to, I think, fairly early take a look at, what is this going to mean, and how can we be best prepared for the surge of patients that we're about to see. So what I want to share with you today is some of the way that we've been thinking about this. I very much wish that I, had some magic beans in my pocket that I could share with you that would be the exact recipe that you need to follow. But like the hospitals within Providence, everybody's very different. And what started as an effort to make a single plan for addressing surge capacity very quickly became more of an overarching principles and things to be thinking about. When you think about doing this for 52 different hospitals in a variety of different states, it becomes very obvious that it's not a top-down sort of approach. This really has to be a hospital unit and even shift by shift kind of approach to this surge planning. So that's the intent in this presentation. And I start with this quote from Donald Rumsfeld: "You go to war with the army you have, not the army you might want." And I think, if we had the army that we want and could perfectly design the care teams that we had, this would be very different. But this is the real world. And we were forced with figuring out how to do this with the resources that are available in different hospitals, and those resources are different for everyone. So we started by setting a set of assumptions. And when we think about designing this kind of approach, here are the assumptions. We believe that we are going to have enough patients, the surge is going to be large enough that we are going to have to shift caregivers into our critical care units who have not done that before. And we believe that we will go from a primary nursing model to a team care delivery model. And we know that we need to prepare our caregivers for that. To support that team model, we're going to have new and people in critical care and med-surg who have not worked in those areas before. But we think we're going to have additional people because we are closing and restricting a lot of our settings. So we have caregivers, it's that medical assistant in the dermatology office that's not seeing patients. It's that registered nurse in short stay where we don't have patient volumes because we are not doing regular surgeries anymore. It's all of those caregivers that are being displaced. And in fact, right now, without a big surge of these patients, we have a lot of caregivers who have time to start preparing to be in an area that's new or novel for them. Now, I think this is important as you're working with your teams. Yes, we believe the COVID-19 patients, we're seeing them suffer from respiratory failure. They have respiratory distress syndrome. They have septic shock. But a lot of those people that are in the ICUs are there because they have comorbid conditions. So to just prepare people for ventilator management is probably not enough. And that was another kind of aha, because I think at first we thought this really is just respiratory failure we have to address. But those patients have other things wrong with them. That's why they're in the ICU quite often. So the driving forces here, if you can think about this in 4 buckets, you've got a people bucket. You've got to make sure that you have the right caregivers doing the right care. Another thing, and we know we probably don't have enough critical care caregivers, so we're going to need to prepare people for that. We look in the places that we're going to be delivering care. When we think about what does a new care model look like, in a 20-bed critical care unit, that's probably going to look different than if we repurpose an operating theater with 2 or 3 critical care beds, or a post-anesthesia care unit that maybe is designed to hold 5 people. That's going to look like a different care team to care for a critically ill patient there than in that 20-bed ICU. So what's the place, the physical location going to look like? Products, we're all suffering from PPE shortages. But what other kinds of products other than ventilators and PPE are we going to be needing? And then finally, what is the actual volume and how sick are the patients really? So that volume and acuity, these 4 things when you critically appraise them, are the things that's going to lead you to what kind of care team do you need to create, and who needs to be on that team, and what skills do they need to have. Now, then, how overwhelmed is the care system? Are we running on regular? Maybe we're getting busy. We're very anxious about what's happening. That leads us to kind of our next level, where our people, places, products, and volume are starting to be stressed. But at the end of the day, in that stressed phase, we still believe that we can take good care of the patient within our four walls. It's really when we can no longer do that in the constraints of our physical environment that we kind of move into that red or overwhelmed state, where we need to start putting patients and caring for patients in places we never have before. So I think these driving forces, if you're thinking about where are we here, these are the four variables that lead you up that triage triangle. So the first thing that you really need to do is identify the team that you're going to have. And for all of us, that team's going to look different. The way that we've really put four bands of team members together. So we have advanced providers. These are going to be, our physicians, our nurse practitioners, our CRNAs, physician's assistants. These are the people that can manage somebody's care, write orders, individually licensed, and that's that advanced provider group. We then have, great staff in our critical care areas. So our professional critical care caregivers are people who do this for a living. And those are the people that are going to be helping to lead our team. So we're really focused in here on the respiratory therapists that work in critical care day in and day out, and our registered nurses who work in critical care. Our focused professional partners, these are people who are, in general, licensed to care for patients. They have their own license. They are professionals. They have their own practice. They have a practice act. They have a scope of practice. These are people like registered nurses who don't work in critical care. They're LPNs who don't work in critical care. They're physical therapists, social workers, but they really are coming from that kind of professional class. The thing is, they just don't have the critical care background. Now, it's important to know what their employment background is. They may have been great critical care providers, in a previous life. So where are they right now as part of that focused professional partner intake process? And then the critical care technician, which we're really looking at this group of people as unlicensed assistive personnel that helps us set their tasks a little bit differently, and it helps us clarify the assignment and delegation function if they're classified as UAPs. I know Ruby from the OSBN is going to be in on Thursday at noon for a similar call where she's going to be talking about assignment and delegation. So our critical care technicians generally are coming from our employees who don't have professional backgrounds. They are not licensed or on a registry. They may be certified. We're thinking about medical assistants, CNAs. We're talking about OR techs and OB techs and emergency department technicians. So these are the people kind of in that technical role that we can put into a UAP role specific to critical care. So, all of the 20, 30 different specialties that we have out there, our first goal, identify the teams. Let's put them into four major buckets of people. Providers, experienced caregivers in critical care, licensed caregivers, not its experience in critical care, and then a UAP technical class. So that's how we've looked at that. Then once you know who these groups are, the next step is really how do you assemble them in a meaningful way and into teams. Halpernon and Tan on the 19th of this month produced an article for the Society of Critical Care Medicine, and they're talking about this team concept all through the paper. This is really the ta-da at the end, where they identify a tiered staffing strategy for the pandemic. And if you look here, there's an ICU kind of attending physician type at the top of this pyramid. RTs and CRNAs, people who really can manage mechanical ventilation, critical care nurses, and then non-critical care nurses and assistive personnel at the bottom. And in this group, they believe that each of these teams could care for 24 critically ill patients at a time. We took a look at this, and this does show up in our documents because it's very useful. But it's probably a little idealistic, a little academic. And when we thought about, could we really create this kind of a team to care for 24, we're not sure that we have that many CRNAs and that many advanced practice providers. We have nurses other than ICU nurses who might be able to fill in that. It got a little bit messier when we started to think about this in a real life setting. So what we ended up doing was identifying roles. That's the critical care nurse, the non-critical care nurse, the RT, the CRNA, and then really kind of the skill groups and skill sets that we were hoping they could perform. So basic nursing care, critical care nursing care, simple ventilator management, advanced ventilator management, and then attending clinicians. And so when we put that into a table, then it started to become more clear to us who all of these different providers and caregivers, really what their skill set was. And so we went from this and then started building some of our teams. So what does a team look like when you've got a CRNA managing ventilator, respirator pieces versus RT versus anesthesia with critical care privileges? And you can see, if you know what the skills are, you can put the teams in all sorts of different combinations. We can't do that centrally within Providence. We know that our individual ministries are the groups that have to put those things together. But this is a way for them to think about it so they didn't have to reinvent the wheel. So once you've got the team assembled, then you have to figure out what kind of preparation and education you need to provide the team. And, at the end of the day, it really is kind of a 4-step process. And our step one is we know that we need to provide some orientation. So here is the down and dirty orientation checklist. And this is where we're going to track and we're going to maintain records so that everybody who gets cross-trained and upskilled, we have a record of that. Then we're going to define the skills that we need to train to. So here are the things that we would expect all of these different caregivers to be able to provide in a team. Then we need to assess people's skills, and when there is a gap between what's needed and where the person's at, we need to provide some education to that gap. And so these are the next 4 steps that I'm going to talk through. So in step number 1 with the orientation portfolio, we're really just looking for a basic orientation checklist that's specific to the hospital and the unit, and then the role that the person's going to have. Gives us a place to document this. It's very important that there's some kind of statement at the end where we deem them sufficiently competent to enter the practice for the level of care that's experienced and expected of the caregivers. So just like any other orientation that you would do, there's an expectation that you have said, yeah, this person's competent to do this work. I would really encourage you to keep this very, very simple. We went back to our agency and traveler unit checklists. These were about the most pared down checklists that we had. And some of you might have a different checklist for orienting students or agencies. I would encourage you to take a look at those because those are probably going to be a more simplified version and a better place to start from than your full-on, 10-page checklist for a critical care nurse. The next is to define the skills and tasks. So we took these roles, that critical care technician and the focused professional partner. Those were the two that we really had to come up with what were their tasks. And we looked at the orientation and competency checklist that we have for the critical care registered nurse. And we started pulling out from that competency checklist which of those skills could really be done by a technical role and which of those could be done by a focused professional partner. Those are the nurse who came from the OR. And then we got very specific about here's the kinds of skills that we really expect people to have and what they're going to need to do in these teams. Once we knew what the tasks were that we were going to expect people to do, now we have to take each individual caregiver and look at their skills against those tasks. So the start of that is to look at their license or certification, what's their education and background, and what's their clinical experience. And that really doesn't have to be nearly as complicated as we sometimes make it. This could be simply in an intake process. What are you certified in? What's your license in? Where's your education and clinical background? And tell me about the clinical experience that you have that would be most applicable in critical care. Or if you're taking somebody into med-surg, it doesn't really matter where you're putting the person, it's just how do you identify what skills they have. And then evaluating those skills with self-assessment. If there's a self-assessment list for people to identify, yes, I know this skill very well, I could teach this. I have done this skill in the past, but I need somebody to kind of brush me up on it. Or this is very foreign to me and I need to have education in addition to validation of that skill. So we used our orientation skill lists. We put those into a table and we're asking these caregivers to complete the self-assessment. And you can see there in the pink bubble, it's the I need education, I need a review, or I could teach this to someone. And that really starts out what kind of education this person's going to need to get there. So you can certainly do group return demonstrations in a classroom setting. We've started to do that in kind of a class orientation to a new area. I know in Oregon, Providence, Milwaukee, and Willamette Falls have been doing this for their med-surg units. And so it's a 4-hour class. They go over some of the basics of med-surg orientation, and they do some skill demonstrations so we make sure that people are really doing the skills correctly. Of course, individual return demonstration is going to need to happen because you can't simulate or make all these things happen in an orientation. That really should be at the bedside, either with another professional caregiver who works in critical care all the time, or even some of our focused professional partners. Think about that nurse who was, 2 weeks ago working in post-anesthesia care. They probably are very competent to check the skills of somebody who's coming from a med-surg unit into a critical care area. Once we've assessed those skills, then you need to provide some education when there's a gap in those skills. And the education, I would be very succinct and focused and create basic educational aids. And remember, you do not have to create all of this stuff yourself. Our Providence subscribes to some decision support tools, things like Lippincott. You may subscribe to Mosby. Many of these are being made public right now. For those of you who have a learning management system in place, like HealthStream, they have released 2 waves of content. And what I'm seeing out there is that the content that was released a month ago for public consumption was really a repurpose of the education that they already have. And it was, to be honest, kind of questionable value. The stuff that I'm starting to see now from the professional organizations, from these content developers that are being released, much better, much more focused on kind of upskilling people from one job to another. And it's really, they're making them available to the public oftentimes through September of the year is kind of what I'm seeing out there. So you don't have to go make all this content yourself. Look to your professional organizations and whatever other product you're using. Think about any residency curricula that you might be subscribing to. We were subscribing to ECHO modules from Elsevier, and we recently got those opened up so we could get people into some of those curriculum as well. Of course, you've got classroom orientation sessions where you have, clinical educator from that specialty who might be able to put a class on in short order. And here's one from our friend Donna Wright in the world of competency, and that's the idea of a learning on the fly competency. So, inevitably, if we really get hit with a big surge, you're going to have people in care environments that, despite your best intentions and your best efforts, are going to come across a care situation for which they really are not prepared. A learning on the fly competency is really about checking somebody's competency in that moment. What do they do when they really don't know the right answer? Do they understand the chain of command well? Do they understand how to get their resources well? Do they understand how to use the members of their team well? And oftentimes, if you can document their ability to do that, that is a really important competency for somebody to demonstrate when they're in a care environment where they're almost certainly going to come across some kind of skill that they're not familiar with. So I would really encourage you to think about that learning on the fly competency. Donna Wright talks about that a fair amount, and there's information just from a simple Google search if you don't know that already. So I would definitely think about that. One of the things that we were able to do was to put all of these kind of materials out on a web page. We went through our Lippincott guide and we flattened a lot of those into PDF documents and then grouped them, by body system. But we knew that that was probably going to be kind of confusing for people when they had to get this education gap addressed. And so we started to put together different educational assets into mini curricula, and we produced those. So you can see here the listing of the curricula that we have. Some of them are pretty obvious, care of the ventilated patient. And we actually have that one as an intermediate and an advanced curricula. We figured we're going to be doing a lot of prone positioning. That's something that's pretty unique to critical care. Nurses from other areas are going to need to know how to do that. And so we assembled our policy. We assembled what we call a job aid, which is a kind of a one-page document that we've created on prone positioning. And then we also have prone positioning in our Lippincott decision tool. So those 3 things should get somebody who identifies in their self-assessment that they really don't know prone positioning. That gives them a small bundle of material that they can go to, learn about prone positioning, and then in the moment get checked off and validated by one of our critical care nurses that they can do prone positioning. Tracheostomy care, a lot of the patients with COVID we're finding are on a ventilator for a long time, and they're tracheing them quite early. We also are, I can't identify this enough, this care for the caregiver. I think for our people that are in critical care, this is going to be pretty traumatizing times. And I really worry about those people who have never stepped foot in a critical care unit or have never been on a med-surg unit, and seen the potential for human suffering that's going to be coming our way in the next couple days and weeks ahead. We need to make sure that our caregivers understand how to identify that they are suffering, and that what kinds of resources we have available to them to help them through this time. So that was a really important element of this bundle. And then the principles of palliative care and hospice care. Thinking through, is there a time where we don't have the space or the equipment or the people to do the care that we're able to provide today? And just putting that into a mini curricula. So this is kind of how we're bundling those educational assets. I do want to point out that we have an external facing webpage with some personal protective equipment resources on it that you are welcome to use. What this website, it will take you to a listing of different approaches to putting on and taking off, donning and doffing PPE. So we have a simple mask, we have a capper, and we have an N95 mask with a single glove procedure and with a double glove procedure. And each of these come with a job aid, which is a quick one-page doff, one-page don, step-by-step list, and a very short video. There also, you can QR code those videos and put them on the job aids so that a nurse with a cell phone in a hospital could click that and watch the video on their phone if they need a quick check-in. So just kind of pointing out, there's a lot of different ways, approved ways of using PPE. We've tried to address them because we have in our system pretty much every different product and every different approach to it. So you are welcome to go there and use those if you find them helpful. And I think that brings me to the end of the presentation.
Great, thank you so much, Troy. That was extremely informative, and I think that a lot of their slides today have addressed some questions that I have been running into with some other people that I've been talking to. So I hope that it was informative for everybody here. While you're starting to prepare your questions and get going in that way, we have a couple of questions that we want to ask you just so we have an idea. So does your organization have a plan in place to transition existing staff into new roles to respond to COVID-19?
We've had just over 50% of the people on the call today participate in the poll thus far. And right now, it looks like about 80% of people say that their organization does have a plan in place. 15% are saying they are not sure at this time. Okay. And the second question is on the screen now.
So the second question is, does your organization have a structure in place to provide additional COVID-19 education for staff? Yes, not at this time, or unsure. Okay, Kelly, where are we at?
Thank you everyone for submitting your responses. Right now it's looking like about 83% are saying yes, they do have a plan in place for providing additional training to staff. 13% are saying not at this time. And we do have a question for Dr. Larkin as well. This is from Charlene Ryan, who's with Coquille Valley Hospital, and she's wondering if you can speak as to how your program might be modified for rural areas or smaller facilities.
Hi, Charlene, absolutely. And, we have many smaller facilities, critical access hospitals within Providence. And, the attempt today and the attempt in this plan is not to prescribe something that fits everybody, because it looks different everywhere. The idea here is that the essential steps that are involved really are the same. And those steps is to identify who are the people that you have at your hospital, however big or small it may be, who are the people that are not going to be needed at this time doing their regular job. Once you know who those people are, you need to define what skills you really need in the departments that you have still open, and look at those people, assess their skills, match them to the right job, and then you're providing that education for the area that they don't have. I think it goes back to that kind of 4-step education process where you've got to be clear about, when I have somebody come into my med-surg unit who's never been on med-surg before, here are the things I expect them to be able to do. And that's going to be a conversation probably between the clinical educator, staff development person, the manager of the department, charge nurses on that department, because they're going to be the ones, making assignments. And that once you know what the care team is going to look like. So, it's the same. I would look at this presentation and say, here's the care team that I'm going to have. Here's the skills that they have. Here's the pockets of skill they don't have. And here's the education that I need to get them up to that. So the process kind of works the same there. I hope that was helpful.
Thank you, Dr. Larkin. I have a second question, and this comes from Timothy Eisenberger, who is with Samaritan Health. And he has heard that OHSU is now allowing procedure masks to be worn by all caregivers, and is wondering if other organizations are having concerns related to opening up the liberal use and inventory levels getting consumed. I don't know if that's something you can speak to, Dr. Larkin, or not.
And so, Timothy, I can talk to you a little bit about the process we followed for universal masking. So universal masking is the idea that everybody in the care setting uses a kind of procedural or surgical mask in the entire hospital. And there are some healthcare systems in the United States who have moved to this relatively rapidly. There are others who are hanging back. The science here is not great. There's not a lot of evidence that this is especially useful. And there's always the possibility that having that mask gives people a sense that they're protected when they're not. That mask becomes contaminated and touched. So it's not without the potential for some people saying that's not a great practice. I have been sitting on our infection prevention calls, and we've been discussing universal masking. Step one, you have to determine if you have enough PPE to support it. If you have a very limited supply of masks, this is probably not a process that you want to jump on until the evidence is a little more clear, because there is very clear evidence that the use of a surgical mask is very useful in other situations. So you would want to make sure you preserve your supply enough that you have it for those situations, and then think about universal masking in the future. We also are thinking about kind of caseload. And we know that is problematic because we don't really know with the limited testing how many patients there are that are carrying this. And we're learning more and more about people who potentially can pass the disease on without any symptoms. So it is an area of controversy. You need to know what your supply looks like. And it's one of those things that kind of once you start doing it, it's hard to pull back. So there's a lot that goes into it. Community prevalence is an important element, as well as your supply of PPE. And there might be somebody else on the call who has a better answer than that.
There's another question, Troy, that has come in, and this is asking, where do you see pre-licensure nursing students in your Reimagined team model, or how is Providence accounting for that, or are they accounting for that?
Yeah, so we do have, in some of the states in which we operate, there is a nurse technician role. So in Washington, for example, there are nurse technician programs where a student nurse can operate in a care setting. It's not necessarily a hospital or not. They have a very specific tasks that they're allowed to do that grow as the person goes through their nursing program and their skills become greater. So once the school has validated the person's performance and competency for a skill, then they're able to do those in the care setting under the supervision of their registered nurse that they're working with. So in Oregon, there is not a nurse technician role, but I think this would be a great conversation on Thursday when you have Ruby in the room of whether or not they're considering that. I know in California, there's at least discussion about that role. We have not, we would put them, in our kind of conceptual model, they would be part of the critical care technician role, because they do need to practice under the supervision and direction of a registered nurse. And so there is kind of that tight supervision and connection of their, what we would call a preceptor probably, together. So we're using that model in Washington. We're very happy to have that model. We kind of related to this is the thought of new registered nurses and how do they get assigned to the NCLEX exam, and how are they able to write that examination with the testing centers closed. And so we're really looking backwards into the old days of having a graduate nurse role, where that person would be able to function as a registered nurse even though they didn't have their licensure yet. If not for the fact that the testing center was closed, they would be able to sit for that exam. And back in the day, that was a very normal process. That happened to me when I graduated, because the length of time from writing your exam to getting the answers was 2-3 months. So that's another thing that we're exploring and having conversations with our state boards of nursing about, is kind of bringing that back so we can use new graduate nurses as we get them hired, and not just leaving them for 2 or 3 or 4 months before they can get their exam taken.
Thank you, Troy. We did have Nancy Ireland with the Board of Nursing pop on to report that the NCLEX testing centers, at least in a couple of locations here in Oregon, reopened on March 25th. And so far, they've been able to keep up with the demand for testing. So they're not at this time experiencing a lag. But I believe the board is also monitoring that and asking schools to report if they do start to experience lag time, to inform the board of that as quickly as possible. There is another question that has come in, and this is from Xenia Saniza with Salem Health. She is wondering if you have started training nurses who are working in IS, the quality department, case management, etc., and preparing them to join the direct care workforce.
Yeah, no stone goes unturned. We are looking for nursing caregivers in all of those roles that you've identified. Now, we still have a need for quality nurses. We still have a need for nurses in utilization review, in care management. So it's a careful balance to make sure that we are not raiding from an area that we really do need. But yeah, we have not put any restrictions on. We've even gone as far as putting a call out to nurses who have retired or nurses who have left the organization within the last year, you know, to, you know, think about coming back. And we're decreasing and lowering some of the barriers of getting those people back in the organization. You know, so shortening orientations and just kind of streamlining the process for getting through onboarding for people who are recently retired or recently have separated. So yeah, we're looking at all of those roles.
One question that I have, there's a lot of people who are educators, who are nursing educators on the call today. I don't know if you can answer this question right now, but is there a way that we can tie nursing education in to assist with anything that you've discussed today?
Well, you know, it all depends on the skill set of the care provider, of the nurse in an academic setting. You know, and what they're being asked to do now, their work of preparing the next generation of nursing students is critically important right now. And we need them, you know, to continue to do the work of preparing good quality new nurses. If they have bandwidth beyond that for some reason, that, you know, their program's over or they're on summer break, you know, we are bringing nurses on board in our organizations. I think to reach out, especially to those hospitals that don't have as many resources, you know, as a large system like Providence might have. But some of our smaller standalone or smaller system hospitals offer your expertise in review of literature, creating an evidence table for somebody, for an infection preventionist who is kind of alone and doesn't have any, you know, colleagues in their immediate hospital. They might really need some help looking at the guidelines for PPE, or, you know, trying to determine reprocessing strategies, extended use strategies. What does the literature really support for, you know, that question of universal masking? I would imagine if I was a single infection preventionist right now in a small hospital, I would be so busy just addressing the needs of the patients in front of me, I really wouldn't have a lot of bandwidth to do some of those other things that nurses in academic settings are very well prepared to do. And just a simple call and offer your service. That might be another thing that they could do. Or if you have a really slick curriculum for some of those mini curricula areas that we identified, you know, those things like infection prevention practices or prone positioning or an intermediate and advanced ventilated patient. Do you have a really great lecture on care of somebody with ARDS? You know, there may be a nurse educator, especially in a smaller area, who doesn't have maybe the expertise to develop that on his or her own, or doesn't have the time right now to do that. So if you are interested in sharing that with somebody, that might be another thing that another way you could contribute.
Troy, thank you. This has been extremely informational and has really put some things into some good perspective.